Malpractice exposure often develops gradually, shaped by clinical decisions, patient communication, and documentation over the course of care. PICA's case closed publication illustrates how risk management functions as an ongoing process throughout treatment and how clinical actions support patient safety while protecting the practice. The patient was a 50-year-old female with a bunion deformity of the right foot. She was a smoker and typically smoked 4 cigarettes per day. Initial conservative treatment included custom orthotics and a CAM walker. Surgical correction was later discussed. Informed consent was obtained, and the insured documented the risks, potential complications, and anticipated recovery time. The patient underwent a Lapidus bunionectomy with mid-foot fusion. 3 weeks after surgery, sutures were removed. The patient later developed wound dehiscence at the surgical site. As the wound progressed, the insured performed a debridement. Drainage continued, and the surgical plate became visible. When bone and hardware were exposed and signs of infection became evident, the insured escalated care and performed aggressive debridement at the hospital. The allegations included improper treatment of the surgical wound, resulting in infection and bone infection, failure to advise the patient on smoking cessation, and premature suture removal leading to wound dehiscence and infectious complications. The case proceeded to trial. The defense standard of care expert testified that the insured acted appropriately by closely monitoring the surgical site and managing the wound using debriding products. At the early stage of dehiscence, the wound was not infected. Once infection was suspected, the insured responded appropriately by escalating care, hospitalizing the patient, and initiating treatment. The defense emphasized that the complication was a known risk of surgery and that the insured's actions were consistent with the applicable standard of care. This included timely identification of complications, careful monitoring, routine follow-ups, appropriate treatment, and prompt referral when indicated. Smoking status was a central issue in the case. Expert testimony supported that operating on a patient who smokes does not violate the standard of care when risks are discussed and documented. The jury returned a defense verdict in favor of the insured. The jury determined that there was no deviation from the standard of care and that the complication represented an accepted risk of surgery that was appropriately monitored and treated. Risk management was present throughout the entire course of care. Surgical risks were discussed with a patient who smoked, and those conversations were documented. Post-operative monitoring was consistent, and care was escalated appropriately when complications developed. Referral occurred promptly once infection was suspected, supporting patient safety and continuity of care. Comprehensive informed consent documentation reinforced transparency and clinical decision-making. Case closed reinforces that malpractice exposure is shaped by decisions made across the full course of treatment. Proactive communication, documentation, monitoring, and timely intervention protect patients while reducing liability exposure. For additional case studies and risk management resources, visit picagroup.com.